and listen. Let's see here. There we go. Okay, there I am. So some of you, I know a few of you looking at the list, some of you don't know me. My background is I was actually going to play professional football in college. I injured my right knee, and as a result, that got me to the athletic training room. And they submerged me into ice cold whirlpool tanks. They hooked me up to ultrasound, electrical stim, massaged me, did all sorts of different techniques. These techniques did work. They got rid of the inflammation, but every time I got up and tried to run or change directions, I kept getting a pain in my knee. I got a pain in my groin, and eventually it was in my lower back. And so this was very frustrating over the years. And I ended up becoming an athletic trainer, doing the same techniques on other athletes. And I eventually went and became a physical therapist. I'm from Toronto, Canada. So I went to University of Toronto. And I met one of my first mentors there, Doug Freer. He was the trainer for the Canadian Olympic team, and he introduced me to osteopathy. And this was while I was in physical therapy school. So, I learned, myofascial, cranial, we learned strain counter strain, all sorts of these manual therapy techniques. And so I started to learn these techniques while I was a student. And I started to get myself treated. My goal was still to go back and play football. And so I started to accumulate, all these different, techniques. I studied hundreds of them. And this was going back late 80s, early 90s. And I was very fortunate because that's when Upledger was starting and Barral was coming to the States. So, I had Jean-Pierre as my teacher. I had John Upledger and the other teachers for him. But I was introduced to any teacher that came through there, Paul Chauffeur, Fritz Smith. I also studied at Michigan State, which is a big osteopathic program. So I started to, take hundreds and hundreds of classes, probably like a lot of you. And so this led to a lot of confusion. And I realized that I was good at treating patients who had, some kind of trauma. But if you showed up at my clinic and you had insidious onset of knee pain or shoulder pain, and I'd hunt around, these are the people I had difficulty with because this type of pain may be due to something else. Maybe due to energy or emotions or some kind of deficiency. And this is what led me to study acupuncture, which was a 4.5 year program. And I can remember being at the acupuncture clinic, and I had a patient came in with shoulder problem, but I was still evaluating and thinking like a physical therapist. And I was looking at all the tense areas in the shoulder, and I was going to stick a needle there. But luckily, we have a teacher there and doesn't allow you to do anything until he examines the patient. So he looks at the patient, he looks at the points I put together, and he says, "Boy, you're really off." And I go, "What?" And he goes, "Did you check their tongue?" I go, "No, it's a shoulder problem. Check the tongue." The tongue was very swollen, very pale, sign of deficiency. "Did you check the pulse?" "No, this is a shoulder patient." So I checked the pulse, and this is a big guy. It was a very deep pulse, very slow pulse, deficiency. And he goes, what was the tone of the voice? I go, "I don't know. Say something." So the patient talks again. He was a big guy, but had a very soft voice. And so everything led to deficiency. So if I sit up here a little bit, and if you see my shoulder, if my shoulder was forwards like this, okay, maybe I'll stop the share for a second so you can see. So if you can see my shoulder coming forward, why is this shoulder forwards? Is it because of all the tension in the front or the weakness in the back? So for me, I was thinking always about tension, 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 but Chinese medicine gets you to think of excess and deficiency. Let's go back to that. Here. Good. And so I had to change my whole point prescription to focus on the weakness. So the weakness is the muscle at the back that was allowing it to pull forwards. So that really changed how I saw things, that instead of just looking for tension everywhere, there can be deficiency. So that was exciting because Chinese medicine also introduced me to emotions as the cause as well. And after taking all these different types of classes, I can remember being in my office one day and a patient came in with low back pain, and I didn't know what to do. I had too many techniques, hundreds of these techniques. I could have done McKenzie technique, Kaltenborn technique, manipulation, mobilization, muscle energy, visceral manipulation, cranial sacral, myofascial, strain counter strain. I mean, there's so many different approaches. And so I started to realize that I had lots and lots of techniques, but I didn't really have a way to organize everything. Because, you could do a general listening, local listening, and Upledger, you do arcing. Some people said, well, you have to start the feet and work your way up. Cranial people said start the cranium, work your way down. Some people says no, you got to start the organs. I mean, there's so many different voices going on in my head. And so this is why I actually went back and went to osteopathic school. I went to 2 schools. I went to one in Hamilton, Ontario, Canada, and I also went and studied classical osteopathy with Dr. Wernham, or John Wernham, in Maidstone, England. That's where I was introduced to this. And so it's fortunate that the osteopathic school I went to, they didn't stress techniques, they stressed anatomy, physiology, and principles, which I'm going to share with you today. They wanted you to make up your own techniques. They wanted you to kind of figure it all out. I also was introduced to John Veltheim, who's a chiropractor from Australia, and he introduced me to energy medicine called Body Talk. And I've been with him since probably the late 90s, early 2000s, so a while. And this deals a lot with energetic medicine and internal lines of communication. So I'm fortunate to be on faculty with Upledger, with my own D'Ambrogio Institute and the Barral Institute. And right here, this chart, the DAI treatment approach chart, we're going to go through this a little bit later. But this is a culmination of 30 years of my experiences. This is put together from all my incredible teachers, Jean-Pierre, Upledger, even Chickley with lymphatic drainage, all the people from Michigan State. So many different incredible osteopaths and practitioners. And for me, and some of you may have the same issue, is that how do you make your decisions? I mean, if you're experienced, you can use intuition, you can use all sorts of different things, but this is more for the new practitioner. How can you help the new practitioner make decisions, right? And so this is what we're going to go through in this talk. So I'm part of the International Alliance of Healthcare Educators. So Upledger, people know the Upledger Institute for the Craniosacral and the Somatoemotional, and obviously the Barral Institute. A lot of you are members of that in Europe. The D'Ambrogio Institute, they asked me to join to bring with it a lot of the techniques, the muscle balancing, joint balancing, fascial balancing, and the lymphatic balancing, which was missing from the curriculum, and also this total body balancing. So we'll show you how we do things. Now, if you want to get in contact with me after this presentation, here's some contact information. I will also put this up at the end of the talk. The d'ambrogioinstitute.com, my email, kerryjdam@gmail. And if you are in Florida, we have a lot of people come in, you can come see me or Jack. Jack works with me here. So today, I put together a few sections. I was trying to organize this. And if you listen to the lecture I did in Spain, I think a week or so ago, it's kind of designed the same way. I want to take you through a bit of a process. So we're going to talk about guiding principles. For me, they're the most important because they're the backbone of how you make decisions. I want to talk about health and homeostasis because osteopathy is a physiological model. So is Chinese medicine. I want to talk a little bit about fascial anatomy because that sort of ties everything together. We'll talk about barriers to this health and homeostasis. This is where we come in as manual practitioners to work with this. I'll address what is total body balancing. We'll talk about why it's important, and then I'll give you an example with a shoulder dysfunction. I used that when I was in Spain. So guiding principles. So these are the principles. These are the things that I think about when a patient walks in. The body is a dynamic unit of function. So let's break those words down. What does dynamic mean? It means your body is changing. Your cells are changing. What that means to me is we have hope. If you did all the wrong things, if you start to change your diet, your sleep, and exercise, your body will change. You'll get a new body in the next 3 months. But it's also a unit of function. What does that mean? Mind, body, spirit. I'm a physical therapist. I'm an osteopath, right? Physical therapist. So people expect you to work with the physical body. And what happens is not all physical problems that come in, right? We're going to have people check your mics there. Yeah. So when patients come in and they have a physical problem, I had a woman, it was 2 weeks ago, she came in, she was having a lot of headaches, neck issues and that, and she's had lots and lots of body work. What happened was this went back and had to do with her daughter. Her daughter was sexually abused at a young age, and her daughter has had issues ever since there, in and out of seeing psychologists, etc., therapists. But as a parent, you're guilty about this. You're angry about this, and these are things that she carries with her. And as her daughter comes in and out of her life, this gets triggered, and this triggers everything else. So when she gets therapy, it doesn't last. But when we started to address this, and she started to understand that, she was able to get this under control a lot better. So I always look at this. We have something called a downward causation. This is from Body Talk. The physical body's on the bottom, and above it is your energetic body, then your emotions, your beliefs, your consciousness, universal consciousness. It's a downward trickle. That means if you have a shoulder problem, let's say, why do you have that? This could be due to a lot of other issues instead of just muscles, bones, joints, etc. And we deal that more in my energy balancing classes. The other thing is the movement of body fluids and energy is essential to the maintenance of health. This is crucial, this one thing, so highlight this one. Because in osteopathy, the rule of the artery is supreme. Okay, and in Chinese medicine, they say the movement of qi is so important. They say that as long as qi is moving freely, you're not going to have dysfunction. Anywhere that it's stagnant, that's where you're going to have issues. So for me, osteopathy is a physiological model. So this is always in the back of my head. So I'm looking at arterial flow, right? Venous return. I'm looking at lymphatic drainage, all these different aspects, okay? This is important for me because you always ask yourself, well, how does something heal? How does a knee heal? How does a shoulder heal? What does it need? And what's the pathway to healing? What's the pathway of drainage? And is there any obstacles in the way? So this is important for us. This is what we have to figure out. The other thing is that you are treating an intelligent body. Right? The body knows. Jean-Pierre talked about this. And Roland Becker says, only the tissues know. So with manual therapy, we're trying to create a better environment because it's a physiological model, a better environment for this intelligent body to take over and heal itself. So as a manual therapist, we want to remove barriers. What are these barriers? Muscles, joint, fascia, fluids, etc. But they can also be emotional barriers, psychological barriers, energetic barriers. Okay, so we have to take a look at all those different aspects. Now, the other thing that's important is that as a manual practitioner, we only have to do enough. And nature will do the rest. The patient will do the rest. We don't have to do everything. I try to only spend 20 to 30 minutes actively with a patient because I don't want to overtreat. And it depends on, this is getting into dosing. It depends on their age. Their vitality is the most important thing. It depends whether they're acute, subacute, or chronic. There are all these different values, but I tend to like to get in, get out, allow their body to, work with it afterwards. This is important too. The nervous system plays a crucial role, specifically the autonomic nervous system. If you look over here at the anatomy of an artery, it's got 3 layers to it. It's got endothelial cells on the inside, and that's where the blood's going to flow. It's got a middle layer of smooth muscle, and the smooth muscle is under the control of the autonomic nervous system, specifically the sympathetic, and then an outer layer of connective tissue. So if you're in sympathetic overload, you can get something called vasoconstriction, where it constricts the blood vessels as they go through. So we talked about that in my last lecture, the lymphatics, is that you need to calm this nervous system down, open it up, and this is going to improve health. So it's something we need to look at. Then the last one is structure and function. They're reciprocally interrelated. So the example here, if you look at this clavicle, the clavicle is a great example. So if a patient has hypomobility, stiffness in their clavicle, why is it important that we mobilize that? We don't mobilize it just to improve, shoulder abduction, because in order for the abduction to occur, that clavicle's got to glide, it's got to rotate. But more importantly is what's underneath the clavicle. We have nerves, arteries, veins, lymphatics. So this is that physiological model. So this is why it's extremely important that we mobilize that. So this could be anywhere in the body. If you're working on ribs around the liver, structure will affect function. Also, if something is not functioning properly, it can also affect the structure around it. Okay, so that was guiding principles of practice. I want to talk about health and homeostasis. So to maintain health and homeostasis, all tissues have to have this unimpaired physiological motion. When I did the lecture on visceral lymphatic balancing, We talked about organs, mobility, and motility. So we need this movement around fascia, around joints. This is important. But we also need a unrestricted flow of these vital substances. You know, the nerves, the arteries, the veins, lymphatics, but also energetic circulation. So remember, we have 4 types of tissues in the body. We have epithelial tissue, we have muscle tissue, nervous tissue, and connective tissue. Now, tissues are obviously created, you know, by cells. So if we take any one of these tissues, let's say it's epithelial, so right here on the surface, and if we put it under a microscope, we'll see epithelial cells. Now, cells of all 4 of these tissues, they're different, but they have common characteristics. They have a cell wall, they have a nucleus, mitochondria, ribosomes, things like that. Those are called organelles. If you put them under a microscope, you're going to see molecules, molecule or 2 or more atoms, like H2O. And if you zoom in on the atoms, right, you have protons, neutrons, electrons. So it's interesting that this physical body that we feel under a microscope is nothing but 99.999% empty space. So how does that function? Well, it's the frequency of vibration. Our physical body is a low frequency of vibration, so we can feel it. And we address this a lot in our energetic balancing class. But the important thing is that each of these tissues needs these vital substances, the arteries, the veins, lymphatics, right, the nervous flow. Now there's 3 factors, right? The first factor is tissue mobility. So in order for health and homeostasis, tissues have to move. They have to move at the cellular level, that tissue level, you know, through functional range of motion and the organs, motility. So movement is health. You know, Jean-Pierre Barral has talked about this. We talk about this in Chinese medicine, throughout osteopathy. So this is very important for us because these tissues, as we'll see later, will create obstacles for the vital structures. So the second factor in health and homeostasis is tissue supply, is that we need this supply to these tissues, to the nervous tissue, epithelial, muscle, and connective tissue, okay? We need blood supply. And the blood supply, it's going to carry oxygen and nutrition to these tissues, okay? Also energy supply. For those that don't know much about energy, energy is created by the food that you eat. So when you take food into the stomach is going to separate the pure from the impure. As it goes down through the intestines, same thing, there's a separation of pure and impure. The pureness goes to the spleen. The impure continues down. The energy from the spleen will rise up to the chest, okay, where it meets air, the air chi they call it. And this is connected with the kidney energy, your original energy. So this creates the chi in the chest. From there, it's going to flow out left and right in your lung, your pericardium, and your heart meridians, which are all on the inside of the arm. So they're going to flow from the chest outwards. So this chest area is extremely important. Once it goes to the hands, it's then going to flow back on the back of it. And this is going to be your large intestine, your sanjiao or triple warmer, triple heater, some people call it, and small intestine. So this flows up to the head. From the head, it's going to flow down to the feet. This is your stomach. So your stomach starts there, your gallbladder and bladder meridians, they flow all the way down to the feet. And then from there, the yin channels come back up to the chest. That's your spleen, your liver, and your kidney. So there's this flow. So you can see that this chest area is extremely important. And in Chinese medicine, this area here is your shen, it's your spirit. So this energy flow is extremely important. And you're going to see later that we can have obstacles to this flow. The other thing that's important too is we need nerve supply. Okay, central nervous system, the brain and spinal cord have a function, but also the peripheral nervous system, your autonomic nervous system, your sympathetic, parasympathetic, and somatic. So that's your voluntary control. You have both sensory and motor. So this will affect all those tissues we talked about. And also, we addressed this already, vasomotion, the autonomic nervous system's effect on blood vessels. Okay. So this, in order for a tissue to be healthy, and again, nervous tissue, muscle tissue, epithelial, and connective, you need blood supply, energy supply, nerve supply. So this is extremely important. So when you understand this physiological model, you can see that, we need this. So we need to make sure that if you have a knee problem, shoulder problem, or an organ problem, what's the pathway of flow towards that body part or organ? The third component that we need is tissue drainage. Okay, so this is an outflow. Okay, so not only do we need blood supply in, but we also need venous drainage outwards. Okay, so what does venous drainage do? So when you think of, your heart, it sends blood to your lungs to get rid of carbon dioxide, so a toxin, but it takes in oxygen, comes back to the heart, and then that heart is going to pump the blood, all right, to the rest of the body. So there's blood pressure. But inside the blood vessels are proteins, and proteins exert something called colloid osmotic pressure. So what happens is that blood flow has to work its way down towards capillaries. And in order for the cells around those capillaries to benefit from this, they need the nutrients. They need the oxygen and the nutrients from what you've eaten. So what happens is blood pressure is greater than colloid osmotic pressure, so the fluid will leak out with these nutrients and oxygen. Every cell needs this, but also every cell gives off internal toxins, so that has to go somewhere. So what happens is these toxins are going to come back in the venous system. Because of the venous system, colloid osmotic pressure is greater than blood pressure. So what happens is everything flows into the venous system. But let's say if 30 liters were to leak out at the arterial end, 27 would go back in at the venous end. And the other 3 liters would be we talk about here, your lymphatic system. So your lymphatic system deals with that other 3%. So in this middle picture here, this is what I'm talking about here, and this is where the capillary bed is that this venous return, right, is taking waste products, probably 80 to 90% of the waste products back to the heart. Okay, so where does it go from there? To the lungs, we get rid of it there. And then as it comes back to the heart, and then it goes down the descending aorta, you have the celiac trunk, and that's going to go to the liver. The liver is going to also be an organ of detoxification. It's going to go down a little bit further to your renal arteries. It's going to go to your kidneys. Your kidneys are going to detoxify. So this is how we detoxify. Also our skin, we sweat it out. So the venous system is so important because it helps to take away this toxicity. Lymphatic system is also important. It's a secondary means to take away this toxicity from the body. And the lymphatic system starts in the periphery. You can see it here in green, and it ends where the heart is. Now, if I go back one, we also need that energy circulation, which we talked about. So the venous drainage, lymphatic drainage, and energy circulation. There's an old saying in osteopathy that drainage precedes supply. So think about that for a minute. Is that if you have a shoulder injury and you've done all the manual therapy around that shoulder, is that in order for that shoulder to heal, right? You as a manual therapist, right? You're a part of it, but you didn't heal the shoulder. You created an environment for healing. You worked on the fascia, the muscles, the joints, all that. But what happens is that venous return, that lymphatic return, that energy flow has to have time to do that. Now, there are additional techniques. We teach lymphatic balancing techniques that actually help to speed that up. But drainage precedes supply. We need to get rid of that toxicity first to allow room for oxygen and nutrition to come in there and to heal. So you as a manual practitioner, you want to understand this physiological model is that at the end of each of your therapy sessions, if you're working on a shoulder or knee, you want to spend a little time doing a little lymphatic drainage. At our clinic, we have a beamer mat. And Jack, if you want to contact Jack or contact me and I'll send it to Jack, but he's our beamer guy. This is a mat that we lie patients on. I'll sometimes do acupuncture on it, but it has a certain frequency to it, and it actually improves microcirculation. So this is an osteopathic principle. It's also Chinese medicine. This is something so important, improving circulation. And again, giving them exercises. We give them exercises to improve upon this. So these are the 3 key factors for health and homeostasis. It's important for the tissues to be mobile because all these vital structures are going to flow through those tissues. So that's why we do manual therapy. But anytime I'm looking at a knee problem, shoulder problem, organ problem, I'm always asking the question, how does it get its supply, right? And how does it drain? What is that pathway? And we'll talk a little bit later about, are there any obstacles in that pathway? So the third thing I want to talk about is fascial anatomy. We're just going to talk about this for just a short amount of time. We obviously spend more time on the full course, but I want to give you a basic perspective. So remember I said that we have 4 types of tissues: epithelial, muscle, nervous, and connective tissue. So we're going to focus on connective tissue because that's what fascia is. So when you look at connective tissue, okay, you look at that little picture off to the right there. It's composed of specialized cells, fibers, an extracellular matrix. And the important thing with this connective tissue is it does what it says. It connects things together. It provides structural support, okay? We have different types of connective tissue. We have embryonic connective tissue, right? We have specialized connective tissue. A lot of people aren't aware of this, and there's a lot of debate over this. You know, fat, it's a connective tissue. Some say it is, some say it isn't, but it's classified as a specialized connective tissue. Bone, cartilage, blood, lymph, they all consider that specialized connective tissue. Now, the third one is proper connective tissue. This is the loose and the dense connective tissue. And this is what we want to focus on, okay? So fascia, if you look at the Fascial Research Congress in 2015, their definition basically is fascia is a sheath. It's a sheet or any other dissectable aggregations of connective tissue. They form beneath the skin, they attach, they enclose, they separate, right? Muscles and other internal organs. Okay, and we're going to delve into this a little bit more. So basically, the key point to start with is fascia is composed of proper connective tissue, right? That third component I talked about. So loose, there's dense, regular, dense, irregular, and there's mixture of all this. So when we look at the composition of fascia, we have cells, and fibroblasts would probably be the most important cells, but obviously there's going to be fat in certain areas, so you know the cells for fat. Also connective tissue fibers, right? Collagen, elastin. So collagen, remember, is a triple helix, like DNA, so it's very strong. It only stretches about 5% its original length, but it's extremely strong. Elastin, they're both proteins, but it's a different configuration. It's more flexible. It can stretch, I think, about 150% its original length. And then we have ground substance, which is like a liquidy gel. You know, it's got water, proteoglycans for shock absorptions, and glycosaminoglycans, okay? So the key thing is what happens to fascia when it gets injured. Our body lays down more collagen in different directions instead of being organized. And also that ground substance, which is normally a liquidy gel, can become very dense, okay? So this is extremely important, the classification of where is fascia. And there's lots of debate over this. I've traditionally talked about fascia in 3 areas: superficial, deep, and the deepest layer. My deep layer includes the viscera, but some people like to separate these, okay, because of embryology. So we're going to separate these into 4 groups that we'll talk about. The key thing I want to mention is even though we're talking about each of these fascial layers separately, I want you to understand that there's no clear division. It's all one continuous sheet, okay? So I want you to keep that in the back of your mind. So here is superficial fascia. So here is the epidermis. The epidermis, if you feel your arm, is the outer skin, the outer surface, waterproof. And below it is your dermis. Your dermis is where your hair cells are, your sweat glands are, okay? And then if you look below it, your superficial fascia is right here, and above and below it is adipose and also some connective tissue. So the superficial fascia is right there. And if you come in and sink in below your skin and you go down to where the muscle is and come just above that, that's the superficial fascia, okay? You look a little bit deeper here, there's your deep fascia and there's your muscle. We'll talk about that. So that superficial fascia really connects the skin to the deep fascia, you know, through this insulation, through this adipose tissue. So here's our deep fascia. And again, this is all that dense, regular, proper connective tissue. And this is going to surround muscles, tendons, ligaments, you know, everything down to the bone. So in this picture, we've all seen this before, you know, the epimysium, right? It's going to cover everything on the outside. The perimysium is going to create bundles. Okay, the endomysium is going to surround the individual fibers, and the periosteum actually covers the bone. So this is, and when you think about all these different layers, start to think about where muscle is throughout your body, and you're going to get these layers all the way down. And also think about what happens to this fascia when it gets injured, which I talked about. Now, as we talk about deep fascia, there's two divisions of it. There's axial fascia, and there's appendicular fascia. So the appendicular fascia is the fascia of your arms and legs. The axial fascia is the fascia of your trunk. And in your trunk, we have both hypaxial and epiaxial fascia and muscles, basically. So remember, the fascia is like a tube within a tube. This axial fascia, we have these hypaxial muscles, right? It's a circular layer of fascia that surrounds us anteriorly. So in the front of the neck, we have the longus colli and capitis muscles in here, and they have fascia that wraps around. But also, this is an embryological picture, but I want you to look where my cursor is here. We have fascia that wraps around like this, and this is the intercostal muscle. So it's like a ring going around the body. And also at the front of the body, which is right in here, the obliques, rectus abdominis, they are covered in this hypaxial fascia. So it forms sort of a ring sort of around the body. Now, if we look at epaxial fascia, this is the fascia at the back. So here, back in here between the spinous process and the transverse process. So these are like two, cylindricals on either side. We have one big cylindrical around our body in the front, and at the back we have those two cylindricals. And this will surround your paraspinal muscles. Okay. Now, what's important here is this axial fascia is going to extend into your extremities. And it does this through the neurovascular bundle. Here's an example, of the cervical thoracic region here. So where you have this neurovascular bundle, the nerves and arteries coming into the arms, there's fascia around it. This fascia is actually going to go into the upper and lower extremities and create basically the compartments, the intramuscular septum. So I'm going to make this here a little bit bigger. Oh, I can make that. There it is. And you can see here, there's the intermuscular septum in there like that. Okay, so it's going to create these little divisions there. So this axial fascia is going to continue into the arms, into the legs. So there's a connection there. Okay, now appendicular fascia. So the fascia that we already talked about, the different layers around the muscles, the bundles, all the way down to the fibrils, all that fascia can also come up into the axial fascia, and it's going to connect to our spinous process and indirectly through our thoracolumbar fascia. It's going to come into the axial fascia itself. So if you look here, you can see, the different septums in here, the lateral and medial septum, and you can see all the different muscle groups with fascia around it. And also remember, there's fascia around the bone. And then down here is the lower arm. Okay, so this is the upper extremity, and fascia is going to surround each of these muscles. Now we also have the lower extremity. Okay, so you can see we have the neuromuscular septum here. Okay, coming in here, and also all these different fascial envelopes. Each muscle has its own bundle of fascia because every muscle has its own nerve supply, blood supply, etc. So just think of that for a moment. Oops, there we go. Right here. Think about that for a moment. If you think about all the fascia, all the different muscles in your arms and your legs, all this is all going to come up into the axial region and influence it. So here's some clinical considerations. So we know that the axial fascia is connected to the appendicular fascia. So this means is that I know a lot of you are doing visceral manipulation. So when you're releasing a lot of the viscera, you are going to be influencing the extremities. When you are working with the extremities, arms, legs, and I can even say the head and neck, which we'll see, you are going to be influencing the viscera as well as this axial fascia. That's the key sort of takeaway point from this. Okay. Now we also have meningeal fascia. And so If you've studied craniosacral therapy, you know you have the pia mater, which surrounds the brain and spinal cord. Then you have the arachnoid matter, and the dura mater is the outer covering. The key attachments for this dura would be the coccyx, the sacrum at S2. So that's the craniosacral axis. So we get the craniosacral motion there. Okay, but also C2 and C3 in the foramen magnum. Also the fascia inside the cranium, the whole brain is surrounded by dura, but also there's a, if I make this a little bit bigger, right there, we have the falx cerebri, we have the falx cerebelli, and this basically divides the brain into a left and right cortex, left and right cerebellum. We have a horizontal, the tentorium, which will divide the brain into four. We have the left and right cortex, left and right cerebellum, so it's divided into 4 sections. Each of these have specific connections. So remember that this meningeal fascia is connected to the axial fascia and the appendicular fascia and the superficial fascia. So what this means is that I could be using an arm or a leg and influencing this craniosacral system, like we just said with the appendicular fascia affecting the axial fascia and vice versa. So we can influence the system through the arms and the legs, and also working on the organs, working on the axial fascia. So keep that in mind. Now, visceral fascia. And I used to keep this basically as deep fascia, but we put it as its own. So this fascia is a vertical sleeve that runs up here from the base. Oh, I got my thing here. Oops. Come back here. Oh, lost my cursor. So it runs from the base of the cranium all the way down to the pelvic floor. And it contains 3 divisions. So there's cervical visceral fascia. This is the fascia all in this region that's going to, surround the trachea and the esophagus, which is shown in that picture. So that picture, you can see the cross sections. In the front, you can see the trachea and the esophagus, and at the back, you can see all the different muscles that pass through there, and they all have a fascial sleeve around that. All of that is going to be continuous as it comes down into the thorax. So in the thorax, and here you can see, I'll make this a little bit bigger there. So you can see the lung. Okay, there we go, I got cursor back. So we have the lung here. Then you remember that on top of the lung is the visceral pleura, which is right here. We have a pleural cavity, and then we have a parietal pleura. We also have an outer fascia, the endothoracic fascia, and this is all going to connect, to that rib cage. Okay, and also the pericardium is also going to have those same layers to it. Okay, the visceral parietal and the fluid in between that. So all this thoracic fascia is continuous with the cervical fascia. If we continue from there down into the abdominal pelvic, the peritoneum, visceral, parietal, and also the fluid in between that. So all this visceral fascia is all continuous, running from the base all the way down to the pelvic floor. Okay, so now we're going to talk about is barriers to this health and homeostasis. Now, when we talk about health and homeostasis, we said that tissue motion was important. We said that tissue supply, so arterial flow, energy flow, nerve flow, and also drainage, venous, lymphatic, and also energy circulation. So what are the barriers to this? So we can have local barriers. So let's say it's a shoulder problem. You can have local issues around the shoulder that are creating a problem for this tissue to heal. You can have protective muscle spasm there. You can have fascial restrictions around the shoulder. You can have restrictions in the joint of that area. You can have swelling in that area or energy restrictions in that area. So these are called local restrictions or local lesions. Now, what I see is that a lot of people tend to focus on local lesions. And there's nothing wrong with that. I mean, I've done that a good part of my life as well. But what happens is that, let's say someone comes in with a knee problem and you go right to the knee. The problem is that the patient wants you to work on the knee, you want to work on the knee,
Kerry, your video and your sound just went. Are you with us?
We
There you
lost.
There you are. I see you again.
Yes, there we go.
Okay, good. We're back.
Okay, perfect. All right. Let's continue. There we go. So now I want to talk about total body lesions. So we talk about, for me, the pathway of healing is the most important thing. What can get in the way of that? Transverse diaphragms. So if I had one technique, if you only gave me one technique to use, it would be transverse diaphragms. Because when you think about these transverse diaphragms, they're horizontal. If they're restricted, they affect the vertical flow of all these vital structures that we're talking about. So the tentorium cerebelli, dividing the cortex from the cerebellum, thoracic inlet, respiratory diaphragm, pelvic floor. In our classes, we spend more time on these. We go through all the anatomy. We tell you what passes through these structures so you can see it, and also how to evaluate it. But these areas are extremely important, and we want to remove any tension, because if we do, again, remember that it affects the inflow to that area. It's a physiological model. It also affects the outflow. Okay? So for me, I'm not going to work on an area locally unless these diaphragms are intact. Also, intercavity pressure. Remember that everything has to flow from a high to a low pressure. I have a class, visceral lymphatic balancing. And what I was trying to teach them is that if you've done visceral manipulation on an organ and there's still congestion in that organ, you can't go to the organ and start to drain the organ. If you have a knee problem or shoulder problem, you can't just go to that shoulder knee and start draining it. You have to take a look at the pathway, because everything has to move from a high to a low pressure. So where does everything go to? To the heart. You have to know that pathway. We talked about that in my last lecture a week ago. So if you look at intercavity pressure, I'll go forward one, is that the area of your thorax is the area of greatest negativity. This is where everything has to flow to. If you look at what's the number one cause of death in the world, heart disease. And this is the first area I always check. Most people are restricted in their respiratory diaphragm and also thoracic inlet. These are two important areas for me that I need to make sure open, and everything has to flow to them. Your abdominal pressure should be greater than the thorax. Cranial pressure should be greater than the thorax. So this pressure here in this thoracic cavity for me is one of the most important areas. So for me, opening up the thoracic inlet, respiratory diaphragm is crucial for this physiology. So again, when you look at this intercavity pressure and you look at the diaphragms, this is crucial for what? For the drainage of all the organs.
Kerry, your sound gone and video stopped again. Maybe go out and come back in again, like you did before. Okay, everybody. Sorry about this. Let's have a small recess to wait for Kerry to come back on. Assuming that's something with his Wi-Fi. Trying to call him, but let's take a little break. We'll be back on in a second, I believe. Okay, I'm sorry, guys. I'm just texting with Kerry. He's trying to reconnect, so it'll be a few minutes until he got the Wi-Fi going again. Seems like everybody else are doing okay, connected, so must be something in his system. The wonders of the internet. Yeah, so Kerry's daughter is telling us the Wi-Fi has been a problem. Thank you, Kelly. So we're hoping that it's going to be solved very soon. Sister, sorry, not daughter. Okay, the word from Kerry is he's trying a different computer. Maybe you can manage to go get yourself a cup of tea or a beer or whatever it is you need. We'll be on again soon as you found a computer.
I just checked with the office. Kerry's internet is having issues, so he's going to try to reload the on a different computer. So what we can try to do is, I don't have his slides, so I can't continue the lecture, but just to give you kind of a little bit more information about what he was talking about is, so from a standpoint of evaluating, and you're looking at these lines of tension, you can do a local approach and just looking at the specific areas, or looking at the total body picture and looking globally. So what I always say when I teach is start global, then go local, then go more focal. But if you're missing the global picture and not looking at the diaphragms, he's going to get into the autonomic nervous system. He's going to get into lines of tension. So you have to evaluate globally to find out before you go local, are you missing anything that may be old injuries, old traumas, lifetime of in Florida here. Most of our patients are Medicare age, which means 65 and older. So usually you have accumulation of issues that you've had, traumas and injuries and repetitive stresses and strains. And those things lay down layers and layers of tension that need to be cleared before you can go do a local technique. So basically when we teach you to evaluate and treat looking at the body globally. And if they need it, treat that first before you go local. And we may have Kerry back on. I see his screen.
Excellent, Jack. Thank you so much for taking over for a bit.
Sure. If I had his slides, I'd just take over. And
I know. Thank you so much.
So we're going to have to do a backup plan for Plan B next time.
Yeah.
What's strange is I'm plugged in directly to the internet.
You're hardwired, yeah.
No, but I am, and there's no reason why it should have gone out. So I apologize. All right.
Okay.
Murphy, blame it on Murphy.
Jack.
We're back. Excellent.
Jack finished it for me, so we.
I didn't have the slides, otherwise I would have.
All right.
You did well, Jack. Thanks a lot.
All right. So where we left off is we talked about barriers, and we have local barriers we talked about, but also total body barriers. So we talk about lines of tension. And we're going to show you how to evaluate these areas. You can have lines of tension coming up from the extremities into the axial skeleton, into the craniosacral system, the viscera, but also from the upper extremities, and also that head and neck, that cervical visceral fascia, but also in the torso. So we look at all these. Let's see. There we go. So here's lines of tension we talked about: superficial fascia, deep fascia. Remember, it's a tube within a tube coming from the arms, the legs,
the meningeal fascia, and also the visceral fascia from the cervical, thoracic, and the abdominal pelvic area. And then finally, the autonomic nervous system. This is an important area because of the vasomotion. And we know that the parasympathetic system is in the cranium. So when you do craniosacral therapy, that's parasympathetic. And in craniosacral therapy, if you look at the vagus nerve, which is cranial nerve 10, that comes out the jugular foramina, which is between the occiput and the temporal bones. And so that affects 90% of the organs. Now, S2, 3, and 4 affects the other organs. Now, there is some evidence coming out that all the parasympathetic is coming up from the cranium, and that the sacrum is sympathetic. We have an article with that. Now, the sympathetic system is T1 to L2, and it's right where that sympathetic chain is. So right in here is that sympathetic chain from T1 to L2. And remember that this autonomic nervous system, it's going to control that vasomotion. So remember, we had 3 layers of fascia. We had the endothelial cells on the inside, we had the smooth muscles, and then we had the outer collagen fibers, connective tissue. So remember, the smooth muscles under the control of the autonomic nervous system, specifically the sympathetic. Okay, so if you're on sympathetic overload, it's going to affect this. So these are the total body lesions. And it doesn't matter where somebody has a problem, the shoulder, the knee, whatever. We're going to give you a little case study at the end. Is that what's the pathway to healing? How does that get its nutrition, and how does it get rid of its waste products, and what's in the way? So I'm not going to work on an area locally until I know that the total body lesions are taken care of. Okay. And for those that do visceral work, at the end we'll talk about, well, how does this fit into what you're doing? So what is TBB? Total body balancing. I called it that, and you're going to see why when I talk about why it's important, because it affects the whole body. This was originally taught to me by John Wernham, my teacher. He was an osteopath in Maidstone, England, and he taught something called classical osteopathy. And I usually will spend more time talking about him, but we only have a short bit of time. But basically, TBB is a full body evaluation and a 5-phase treatment program. And it's in supine, prone, side lying, and sitting. And there's a reason why, and I'll go over why that's so important. But the importance of this is releasing these lines of tension, releasing and opening up the diaphragms. And the way that we do this is gentle rhythmic motions that help to calm the autonomic nervous system down. So there's 3 things that we talk about in TBB: the wedge, the lever, and the screw. Now, the wedge is where you put your hand. So if you look in these pictures, wherever my sensory hand is, so wedge is also the sensory hand, the area that I want to treat, okay? So the wedge hand is focused on that specific area. Now, you will have a motor hand, and the motor hand's on a lever, okay? We'll talk about levers in a minute. This sensory hand, whether it's on my clavicle or on the spine, can be passive, meaning you can just sit there, or it can be active, meaning that it's moving and mobilizing, okay? And it's also there to perceive change. Because people always say, well, how many times do I do this technique? Well, you do it until you create a shift, okay? A lever. People always ask, well, what is a lever? So if you had a big boulder, a rock, and you had to bend down and pick it up with your hands, that would be a short lever technique. But if you grab this long 2x4 and put it underneath it and tried to move it, that's using a longer lever. Longer lever has more force to that area. For visceral manipulation, if you put your hands on the liver like this, that's more of a short lever technique. But if I use a leg or an arm to influence it, that's a long lever technique. So lever, it can be your head and neck, it can be arms, it can be legs, it can be the torso. And we have a motor hand, which is on, it guides the lever. The sensory hand or wedge hand is palpating where you want it to treat, okay? And it's important to make sure your sensory hand and your motor hand are connected through this lever, and we call a feather barrier. And so as that releases, then we move to different barriers. We progress superficial to deep, right? And then we start to open that area up. So you don't want to hammer away at it. The screw is this circumduction movements that I do. It can be a pumping motion, But a lot of times it's a certain rhythmic oscillatory movement. In some areas, the direction can be very important because it goes along with the biomechanics. In other areas, you're just basically using it to work on lines of tension. So the wedge, the lever, and the screw. So why is TBB so important? We know that a properly functioning musculoskeletal system is critical for this maintenance of health and homeostasis that we addressed at the beginning of this talk. So this is important. This is what we're focused on. So TBB, when we use the arms, the legs, the head and neck to use long levers to rhythmically mobilize through the body, we are going to release tissue and improve mobility and motility. We're going to balance the tone of the fascia, the muscles, the bones, and the joints. Because we're releasing these tissues, we are going to affect inflow, outflow, energy flow, everything throughout that area. So it's a physiological model. It's also going to affect all the fascia. Okay, it's going to affect that superficial fascia, the deep fascia, the appendicular fascia, the axial fascia, the fascia of the craniosacral system, okay, and also the visceral fascia. And remember, it's all interconnected. Okay, it's all interconnected. So I could pick up a leg or an arm and I could influence all these different systems in the body. That's one of the reasons why I call it total body balancing, because as I start to use the arms and the legs, I'm releasing tension in those arms and legs through the appendicular fascia, but I'm also affecting the axial fascia. I'm affecting the deep craniosacral system. I'm affecting the viscera. And also, if I do it in a very rhythmic, gentle way, I'm affecting the autonomic nervous system. If I do it in a gentle pumping way, I'm affecting fluids. I'm affecting a lymphatic pump. Okay? So it balances the transverse diaphragms. And remember that they are the barriers for all our vital structures, nerves, arteries, veins, lymphatics. And again, if I do it very rhythmically, I'm addressing the autonomic nervous system. So at the end of it, we see better posture, we see better range of motion. And the key thing that I'm after is a balanced homeodynamic state. This is what I want. So finally, we get here to the end, and we'll talk about, we'll give a shoulder as an example. So let's say a patient comes to you, and I use this example in the visceral lymphatic balancing class. We'll just take it from a different perspective. So where do you treat? Well, patient wants you to treat the shoulder. Doctor, if a doctor is sending a patient to you, they want you to treat the shoulder. You want to treat the shoulder, you want something to treat, and that's the easiest thing possible. But it's a key question we ask. You know, where do we need to go? Is the problem here at the shoulder? Is it coming from an organ? Is it coming from a nerve? Is it local? You know, is it more total body? So this is the first thing I address. Is this shoulder problem a local problem? Or is it a total body problem? Okay. If it is a local problem, what do you treat? Okay. So locally, I'm going to treat muscles and fascia, or the joints or bones or fluid or energy. These are all things that I can address locally, or even emotions. Right? If it's total body, and what I mean by total body is what are the barriers in the way for this pathway to healing? Transverse diaphragms, intercavity pressures, lines of tension, autonomic nervous system. Okay? Now we're coming to this chart. Okay, so it took me 30 years to put this chart together, but this is how I think. This is how I process things. So the first thing I start with is a screening examination. Now, I incorporate other things, but I'm not teaching visceral manipulation. I'm not teaching cranial. I'm teaching this. So yes, if you do general listening, you can incorporate that in your total body screen. If you do arcing, if you feel the cranial rhythm, this is where you need to go. If you use your intuition, this is where it's going first. So what are you trying to decide? If I go back, in your screening examination, you're not trying to decide where to start just yet. You're trying to decide two things. Is this a local problem or is this a total body problem? That's the only thing you're trying to decide at this point, okay? So what's our screen? This is our screen. I start with a postural scan. Okay? So the first thing I do is I look at the base of the skull. Is it level? or is there an asymmetry? Now, this is a quick scan. Obviously, if I'm going to evaluate someone more specifically, I'm going to evaluate the occiput, I'm going to evaluate the temporal bone, because this is going to tell me something about that vagus nerve coming out that jugular foramina. I've treated over 30,000 patients, so I can do a quick scan like this because I'm always checking every cranium, and I go, wow, if this is level, a lot of times, pretty good motion here, but if this is twisted in this direction or even in a transverse way like this, then I'm going to find restrictions. Remember, a quick scan. I'm just trying to find out if this is total body or local body. I can place my thumbs at the sacral base. Do I see any unleveling there? So this is a parasympathetic evaluation. And I quickly do that. So patient's back to me, I look at the occiput, look at the sacrum. Then I'm going to run my fingers down either side of the spine from T1 to L2. I learned this from a lot of the old osteopaths, and they would have the patient in front, they'd flex them forwards. They'd actually do a motion test, which we teach in the TVB class. But they'll run their fingers down, and this is a quick visceral scan, right? And it's a sympathetic nervous system scan, ANS. Remember, T1 to T5 is your heart, your lungs. It's, the head and neck. And T5 to T9 is going to be your liver, your gallbladder, stomach, spleen, portions of the duodenum, pancreas, etc. So it is a visceral scan. Do you notice any asymmetry? You could also, if their shirt is off, is there redness or blanching? Redness is acute, blanching is more chronic. Is it focally tender or more diffuse? Focally tender is more acute. Is it moist? That's acute. Or is it dry? That's chronic. Does it feel ropey? That's chronic. So again, you can see if this is acute, chronic, and you can see which level it's affecting. And remember, T1 to L2, the sympathetic nervous system affects vasomotion. This affects that flow, okay? Then I'm going to evaluate the upper and lower T lines. So this is the level of the shoulder and the pelvis. So for me, this is a quick assessment of the appendicular fascia, the fascia from the arms and the legs coming into that axial fascia. What is the influence of that? Okay, so to put it together, this is a quick scan. Remember, you want to do this in under 5 minutes. This is a quick scan. And again, your decision-making is, look at this lady here. Occiput's off. This is the woman I use for my videos. Shoulders off, pelvis is off. You can't see it, but her sacrum is off. So if you find lots of findings, she's a total body patient. Okay? But if all those things were level, like each time I treat somebody and I bring them back to my clinic and I say, oh, you're holding here, it's better here, it's better here. Then you start to see what normal looks like. You go, you're doing pretty good. And then you check, what do we check next? Lower extremity. So now I'm going to pick up that leg. I'm going to feel the weight of it. Why do I want to feel the weight of it? Is there congestion in the leg? Is there a fluid component to this? I'm going to do a leg pump. And when I do a leg pump, I'm actually pumping all the way to the cranium and then tractioning back. So a leg pump is compression and also distraction. And a leg vector is a circumduction. So this is my scan for fluid in the legs or any type of fascia restrictions from that appendicular fascia of the legs coming up into the axial area. And I will compress into it and I will traction from it to see its influence on it, because it does influence it. And then I'll look at the upper extremities. I'll feel the weight of each arm. I'll do an arm pump. Again, the same information. I'm pumping into the system. Remember, if you can't pump into the system, it's congested. And then I'll distract it. I'm feeling a line of pull. And also I do an arm vector. I'm feeling for lines of tension from that appendicular fascia coming into the axial trunk. And then I look at the head and neck. I feel the weight of it. I'll rotate it left and right. I'm checking that tentorium, but I'm also checking that visceral cervical fascia, seeing its effect into the torso. Okay? So now I'm into the thorax. So when I'm into the thorax, I'm going to do a rotation through this upper trunk area, right? And this evaluates for me what's happening in the thoracic inlet, but also what's the nature of the feel? Does it feel boggy? Because remember, we have a lot of lymphatic drainage that comes back into this area. I'm also going to do a sternal pump. So that's this second picture here. The sternal pump, remember, everything flows back to the heart. Heart disease is #1 killer. Is that people are restricted. The next test is lower thoracic rotation, is I'm checking that respiratory diaphragm. So for me, the respiratory diaphragm, thoracic inlet, the sternal pump, this is critical. And I find this stuck probably in 80% of the people. And if it is, then you're a total body patient, right? Because remember, if you have a knee problem or shoulder problem, it has to flow to the heart, right? If your heart's all blocked up there, how's it going to get there? It has to flow from a high to a low pressure. Okay, so we have to clear that pathway. So this is critical. These tests, and again, when you do these tests, I'm feeling the end feel. I'm feeling the quality of the feel as well. Okay, pelvis. So in the pelvis, if you look at this picture here, this is drainage. So drainage coming up through the groin, up into cisternochyle. This is the respiratory diaphragm. And this drains all up into the thoracic inlet to the heart. So this is all lymphatic drainage. So I do an abdominal pump by placing my hand between the xiphoid process and the umbilicus, and I'm compressing in this area. If it feels full to me and your respiratory diaphragm is restricted and thoracic inlet and your sternum, that's congestion for me. It's total body, but it's lymph balancing total body. So I'm trying to decide, is this total body? And also these tests are telling me, is this a fluid model or an orthopedic model? Okay. And I'll also do a pelvic rotation. So all these rotations of thoracic, respiratory, pelvis are evaluations for diaphragms. So that's my screening. So how do we know I need to treat the shoulder? I'm not finding these total body things. If you have a right shoulder problem, I expect to find tension in your right shoulder. I might find it in the right thoracic inlet, maybe ribs on that side, that's fine. If I don't find problems in your legs or pelvic diaphragm, respiratory, otherwhere, or even in your sympathetic system, parasympathetic system, if it's just local to that area, for me, that's a local problem. Right? That's fine. And if it's a local problem, if you look here, right, this is where I do my evaluation. And you can see at the bottom, we have muscle balancing, fascial balancing, joint balancing, lymph balancing, energetic balancing. So right now, the screening examination tells you where to look. So now you know you're going to treat a local problem, but now you have to decide, well, there's lots of anatomy there. What am I going to do? So again, I use ARTS. Anytime I evaluate, this is the easiest thing to do. A stands for asymmetry. Put your hands on the shoulder. Is it asymmetrical? Asymmetry doesn't tell you what the problem was. Do you remember at the beginning I told you about my shoulder being forwards? That's asymmetrical. But is it being brought forwards because of tension in the front or weakness in the back? So asymmetry tells you that there is a problem. The next thing I look at is R. R stands for range of motion. So we teach you to evaluate active and passive range of motion. What's the end feel like? Like if I'm lifting your arm and it feels heavy, that's congestion. It feels soft end feel, boggy, that's swelling. If I pick your arm up and when I bring it to the available range of motion and it feels hard at the end, that's more joint. If I bring it up and there's a limitation and there's a firmness to it and elasticity to it, that's fascia or it's muscle. T, these are important now. Tissue tenderness. So if I'm seeing asymmetry, I'm seeing decreased range of motion with a firm end feel, and I'm palpating around and I'm finding a lot of significant tenderness, and we use a scale from 0 to 10. So it's a 7, 8, 9, 10 out of 10. That tells me it's protective muscle spasm. I've been doing this 30 years, protective muscle spasm. Or we have asymmetry, there's decreased range of motion, and it's a hard end feel. And I go to the tissue tenderness, it's just a little bit, but the key finding is joint tension. Okay? When I mobilize sternoclavicular, acromioclavicular, glenohumeral, I'm finding normally they should be soft and supple, but if they're hard and rigid, that's a problem. Okay? The other thing is tissue texture changes. So we see an asymmetry, and as I lift that arm up, there's a soft end feel, the arm feels heavy. And if I feel tissue texture changes, I feel a temperature change maybe, and it feels a sense of fullness, that's telling me there's swelling. Okay? Special tests. I can do a fascial glide there. So if I had asymmetry, firm end feel, right, at the end, and not much tenderness, not much, joint tension, there's a little bit, tissue texture change a little bit, but when I do a fascial glide test, that's most significant, it's fascial. Okay. So limb weight tests, when I lift the arms and legs and head, if it's heavy, that tells me it's congestion. I always, we didn't have time for it, but if I do a specific eval, I'll always check the proximal nodes. So for the legs, I check the groin. For the arms, I check the axilla. For the head, I check supraclavicular. Do they feel full? Now again, in my energetic balancing class, we teach you to use your intuition. We teach you to ask the body yes and no, and we always go back and verify it with an orthopedic eval. Those that do visceral manipulation, again, general listening, local listening, or upledger, arcing, craniosacral. You can also do muscle tests, orthopedic tests. There's so many tests. I lump all these together as special tests. So depending on what you're doing. So remember, you're a lawyer. You're trying to build a case, okay? First of all, is this a total body problem or a local problem? Okay, it's a local problem. I'm going to treat the shoulder. Now I'm going to find out what's the evidence. Oh, there's asymmetry. Okay. But then you got to decide, okay, what's the range of motion like? What's the end feel like? Hard, firm, soft. Any tease, any tenderness, tissue texture changes, tension. Special tests. Are you getting a general listening, local listening there? When you feel the cranial rhythm, does it stop in that area? So again, you put all these things together and then you create a plan. Don't just treat where the patient is complaining of. If I only had, and Jean-Pierre taught me this, if I only had 20 minutes with a patient, I would spend 15 minutes evaluating, 5 minutes treating. So this is the criteria. No total body lesion, tension found locally, and I'm either going to treat one of those areas, and it's the ARTS evaluation that decides whether I'm going to treat the muscle. Tenderness is the key finding. Fascial balancing, more fascial glide. Joint balancing, more tension in the joints. Limb balancing, limb weight. Tissue texture changes, proximal nodes. Energetic balancing, we didn't talk about that. If nothing else makes sense, it's energy, right? It's energy. And you look at the history, you look at what's happening in their stress levels, okay? Now, what's the criteria for total body? If I find the diaphragms are restricted, I find lines of tension in other parts of the body. Remember that appendicular fascia can come up and affect the axial fascia and vice versa. If I check your autonomic nervous system, that means there's going to be vasoconstriction. You're not going to be able to heal. You're not going to be able to drain that area. You're not going to get good blood supply. So for me, I will not treat locally until I treat this. Now, it doesn't mean I always do total body first. It means I evaluate. You always let the evaluation decide what it is you're going to do. So here, if I can make this bigger for you. So here for total body, remember I need to decide, it is total body from what I found, but from all those tests I did, is this a fluid problem or is this an orthopedic problem? You see, if you have a lot of tension in your sternum, thoracic inlet, respiratory, and abdomen, and legs are heavy and I can't compress, that's a total body fluid problem. In TBB, I'm going to show you something. We'll go over about 5-10 minutes. When we treat with total body balancing, which is skyscraper principle, treating from the foundation up, right? We start at the legs and work our way up. If you tried to do that for limb balancing total body, you'd totally screw the patient up because everything has to move from a high to a low pressure. So if it's total body, but it's more congestion, you have to start at the heart and work your way out. If it's an orthopedic problem, you start at the feet and work your way up. The head, the shoulder, this is the penthouse. Start at the bottom, work your way up. If it's fluid, start at the heart, work your way down, but make sure the diaphragms are open, ANS is open. Now, I have energetic balancing total body. So I work with holograms, okay? We work with energetic holograms. So we can work everything in the body. We can take out a muscle, joint, visceral. we can have your whole body. And I think you can go on their website and see. We're going to be teaching energetic balancing in a few weeks from now. But this is very powerful stuff. So we can treat it locally as energetic balancing or the whole body. Okay. So this is the DAI treatment approach chart. This is how I've built all my classes at DAI, and it's all based on what I learned from Jean-Pierre, John Upledger, Chickley, all my great teachers, Michigan State, etc. So let's talk about TBB very quickly. So we start in the supine position. Why? Well, we want to release, we call this the bowstring, which I'll talk about in a minute. I'm going to use the legs, different techniques on the legs. Remember that appendicular fascia is continuous with the axial fascia and also continuous with the visceral fascia and also the meningeals. So when I use the legs, I actually, during the class, I have people palpating the cranium while I'm doing this, and they can feel things opening up in the cranium. And I have people palpating the organs, and they can feel things changing in the organs. So you can begin to work on this and begin to release your influence on those particular areas, releasing that dural tube. I'm starting to open up the diaphragms, and if I do it in a very gentle, rhythmic way, I'm influencing the autonomic nervous system. As I work my way up to the pelvis, I can palpate medial to the PSIS, and I'm opening up this area, but I'm also affecting the pelvic floor. And remember, we have lymph nodes there. So as I'm doing this in a very gentle, rhythmic fashion, I'm affecting the autonomic nervous system. I'm creating a pump, but also this particular movement is affecting the craniosacral system. It's also affecting the visceral system. That's why we call it total body. Then I come up to the arms. I release the appendicular fascia of the arms into the axial fascia. And again, I'm trying to influence the diaphragms, lines of tension. The arms will influence the craniosacral system. And if I do it in a relaxed, rhythmic fashion, I'm going to affect the autonomic nervous system. I want to open up the rib cage. Remember, the viscera is all attached to it with pump handle and bucket handle motions. So this is how the old osteopaths did their cranial work, did their visceral work through these long levers. I can go down into the arms, do specific work in the wrist, in the elbow, in the arm, again, to further release that appendicular fascia. This is the bowstring. This is a key theory. If you think of the string, this would represent the organs and the diaphragms. The shaft of the bow would represent your spine. So if this string is taut, therefore the shaft of the bow is rigid. And so if you try to go directly to the spine and work on it, if the viscera is restricted or the diaphragms are restricted, it's going to keep coming back. So if you were to lie somebody face down, right, and all their whole bowstring is restricted, good luck trying to mobilize or change anything. So this is why we work on this phase first. Then we get up into the neck. Remember the neck, the head and neck is the penthouse. We've released all this tension. And I've checked this out thousands of times. Once you get up there, the craniosacral system is starting to change. If I'm going to do cranial work, this is when I do my cranial work. If you look at the facets here, you can see the orientation. So when I'm working here on the neck, I'm aligning myself up with those facets. So I'm pulling in the direction of the nose to release tension. And this is getting into that cervical visceral fascia. It's getting into the cranial system. So it's opening up from the top down. Now I get into prone. So once the bowstring's open, I've released lines of tension from the arms, the legs, the head and neck, the diaphragms are open. Now I can place you on your stomach and I can begin to work the spine. If you notice here in the lumbar spine, the facets are in the sagittal plane, okay? So because of that, if you lie them on their stomach and you try to mobilize that sacrum side to side, you're gonna hit it. So this position is much better for the thoracic spine. Look at these facets. They're in the frontal plane. So in this picture here, I'm hooking on the spinous processes. I'm mobilizing here with my motor hand. This is my wedge or sensory hand. And as I create a fixed point and I'm mobilizing that sacrum, because we've released all the tension in the front, what's happening is that these facets here can glide past each other. So they just melt away. It's just beautiful. Now remember, the autonomic nervous system is found where the ribs come into the transverse process. So I can place my hands laterally over that costotransverse joint and very gently and rhythmically begin to tease it out and open it, I'm influencing again that autonomic nervous system. So here's showing you the lumbars. So the best position to treat the lumbar spine is in side lying, okay? And we show you 3 or 4 different positions for doing that to release that tension. And then we finish up in a seated position. So we're treating in supine, prone, side lying, and seated. We're releasing lines of tension in a weight-bearing position, non-weight-bearing position. Now our curriculum is that we have TBB1 and Total Body Balancing 1 is teaching you sort of what I showed here is a full body. We teach a screening examination. We didn't show you the full body evaluation. We teach that. And we also teach you the fundamental treatments, which is supine, prone, side lying, and sitting. And in level 2 and 3, so level 2, what we do is that we add more evaluation. And we start to look at specific parts of the body, like the ankles, the knees, the hips, SI joint, lumbar, thoracic, cervical, the ribs, shoulder, elbow, wrist, and hands. And what we do is we look at, well, how can we treat these just in the supine and prone? So this class is very specific. So let's say you did a TBB1 on someone, but they still have tension. Well, then you can, depending on where you found that tension, you can work on a shoulder or knee in a supine or a prone position. Okay. In level 3, we do the same thing, work on all those different areas, but now we work in side lying or sitting. I've had people come to me sitting in a wheelchair. How are you going to work on someone sitting? Or I had somebody who had sciatica. What's your most comfortable position? They said standing with my knee bent. So you have to treat them in standing. So again, the easiest way to treat is TBB1. But what happens is you have some patients, I can't lie on my stomach. I can't lie on my back. I can't lie on my side. So in TBB 2 and 3, we give you more techniques, but additional ways of treating. Now, we've combined those 2 classes together. We call it TBB 2-3, and we teach it every year. Jack does, actually, who you met. So Jack teaches that at Upledger in December every year, and he reviews TBB 1 and teaches all these specific evaluations and treatments. So again, here's my contact information. I apologize, we lost internet connection. I didn't think it would happen because I was actually plugged into it. So something happened here, I had a short. But I'll address any questions now. I'll stop this. There we go. Where's Kerry? Did we lose him? There he is.
Hello. So how about if you have a question, you put your name on the chat line so we can point you out and ask you to unmute. So anybody has a question, please put your name on the chat line for us. Nobody actually did write up a question along the way, so we're waiting until the end. So here's your chance.
So either we were very confusing or complete, one of the 2.
Yes. Take your pick, Kerry.
Maybe Jack saved the day when I was muted. He explained it. Jack, do you want to chime in and add anything? Jack? You there? There he is.
There I am.
You want to chime in on anything?
No, I think you did a really good job. I couldn't have done it better myself. Gary's a very good teacher. He's been my mentor. And if you get a chance to take a class with him, I highly recommend it. Obviously, with this virus situation, we've had to switch game plan and we'll be going virtual. So I'm in the process of converting the evaluation course into a virtual course. But I know Kerry's working on the energetic course, which is coming up in June. But he's also working on the total body balancing to do a virtual course too. So we're working to still provide value for everybody, but obviously we're going to have to do it in a different format.
Oh, for those that want to know, we are doing a 4-hour total body balancing class. I think it's May 30th from 12 to 4, I guess, on a Saturday. So it'll be 3 or 7 hour difference for you guys. Well, it'll be just your evening then. But if you are interested, You
Here's a
can,
question from Jeanette. Damn. Does it matter what hand you use as your sensor and treatment hand?
so because the total body balancing is like it says total body, we want to work the left and the right side of the body. You need to use both. And so when you're on one side, one hand's the sensory, one hand's motor. When you're on the other side, it's opposite. And you'll see beginner students have difficulty with this because we all have our favorite hand. But I found that after doing this for many years, both my hands can work equally well. And I think it's good as a manual therapist, whether you're doing visceral work or any other work, to make sure that you can feel with both hands. Now, from a clinical, a teacher's point of view, we try to make it simple. Here's sensory, here's motor. But actually, both are sensory and both are motor, especially if the sensory hand is moving and is mobilizing. But you want to be able to feel. The key thing is making sure you're working at that first sign of resistance. Okay.
Well put.
So if you do have questions later on, this is my contact information. I do answer all my emails with a few sentences. I'm not a long email writer. Too busy.
So would we be a similar thing for visual manipulation? You would always start with your dominant hand to use that for your listening and for your treatment. Eventually, once you've been accustomed to listening, you may be using the secondary hand to bring that in as well.
Now, for those visceral students, because I'm teaching for the D'Ambrogio Institute, but I also teach for Barral, is that you're taught to go to the dominant lesion. Okay. I'm not here to tell you which way to do things. I'm giving you a different point of view, but I'll tell you my feedback that had visceral students taking the TBB class is some have done all their general localing evaluation. They did the screening examination. And what some of them did is they balanced the diaphragms A and S, and they found that a lot of the visceral restrictions went away, but then the key ones were still there. And they found that when they worked on it, it released much easier. We actually did a study at Upledger where we brought in a patient and we had a visceral evaluation from a practitioner, a cranial evaluation, and I did the TBB evaluation. And then they all evaluated, and then I just did phase 1 of TBB. And what we came back with, the consensus was, oh, less cranial, less visceral. It didn't get rid of everything, because I think all therapies are important. But what they both said was that it was much easier, much clearer to feel the cranial dysfunction or the visceral dysfunction. Those people practicing visceral manipulation, you can do your visceral work first. And then at the end, if you want to integrate with TBB, you can do that. You can do it either or. For me, it's not about technique, it's about evaluation. If I evaluate someone and that liver is extremely restricted, I'm going to start with the liver. I love Bruce Lee. Bruce Lee, I grew up watching all his movies, and he studied all these different martial arts. But he had this great saying. He said, embrace the principles, but don't be bound by them. Embrace the principles. So study from all sorts of different people. When I studied from Jean-Pierre or Upledger or any of them, I would follow it exactly the way they did that, maybe for a year or two. And then I would you find your own way and you start to mix and match because you're continually learning. And yet all of you basically have to find your own pathway. But I think it's important to respect your teachers, embrace the principles, understand the way they're taught. In order to help that person, follow that person on the table, sometimes you got to change plans. So there's times where I'm starting local and there's times I'm starting global. I'm not tied to any approach, but I am tied to evaluation. Always evaluate. And then the treatment is dependent upon your evaluation. Because remember I said earlier, the body is a dynamic unit of function, mind, body, spirit. So again, you can be the greatest manual therapist in the world. If this is an emotional problem, like that one woman I treated a few weeks ago, her daughter being sexually abused, or somebody just treated 2 days ago, her issue was all about her not feeling respected, or issues with her kids and her husband, and nobody listening to her. And once we acknowledge that, everything just released. So you are an energetic being. You know, mind, body, and spirit are all together. You're not just a physical body.
Excellent, Kerry. So is there any more questions? Nobody wrote anything up. So it's your last chance to put in a question. Otherwise, we can let Kerry go for the rest of the day. Probably
I got patience.
You have patience. Yeah, I would think so. For me, it's 8:45 in the evening, so I have the sofa waiting. All right. So,
Well, Kåre, thank you for having me.
Yes, for me, I'll say thank you very much, Kerry, for spending some time to show us your knowledge and your experience. Thank you very much. And for everybody else, I want to say that my plan is to bring Kerry to Denmark for, first of all, the visual lymphatic balancing class, which is the plan that we're just discussing, the details of which day it will be. So
I'll tell you a little bit about that class. Jean-Pierre, I met with him in New Mexico. I actually had to treat him and his wife for him to approve the class. And he wanted me to set up a class for his visceral students. So I've taken all my information. I'm not teaching it as a DA class, it's a Barral class. So I had to turn everything around so it met his approval and followed the belief systems of that institute. So in that class, we're going to teach you lymphatic anatomy as it pertains to the organs. We're going to teach you fascial and autonomic nervous system. We're going to teach you a lymphatic full body evaluation. We're going to teach you techniques to release lines of tension in the arms, legs, head, and neck, open up the diaphragms, balance the autonomic nervous system. You're going to learn the pathways of each organ, how they drain towards the heart. And then you're going to learn lymphatic balancing techniques in order to drain things, proximal, distal, distal, proximal. And you're also going to learn exercises that are going to help, that the patient can do at home to help with that. Like I said before, if someone has swelling in an organ, you can't start with the organ, right? You got to look at that pathway from that organ. So we're going to observe that. Any barriers in the way, and we want to clear that pathway, proximal, distal, distal, proximal. The first class is 3 days. It's a kind of a total body class, and it's there so you can understand general drainage. And then future classes we're putting together that are going to go specifically, how would you drain a liver? How would you drain a lung? We are going to show you the pathways for each of those. But like anything else, you can get very, very specific. So the first class is very broad, and then we're going to get more and more specific with future classes. Okay. We also have lymphatic balancing for the upper lower quadrant, total body. So our curriculum, our total body curriculum is TBB for orthopedic patients, lymph balancing total body for fluid patients, energetic total body for the energetic, and then our local treatments are all muscle, joint, fascia, fluid, energy. So local and total body. Because at the International Alliance, each institute is different. We don't try to copy each other. Upledger is very different from Barral, and both of them are different from myself. But together, our goal is actually to create an osteopathic curriculum. And the beautiful thing is you don't have to go away 4 years to school. You can sample from the different institutes, and you can, depending on your belief system and what you like to do, you can create the way that you evaluate and treat your clients. How do you know you're successful? Your patients will tell you.
all right, beautiful. So no last minute questions. Then I will then thank you, Kerry, again. And
Thank you.
Very nice that you
Bye, everybody. Stay safe.
want to spend the time here.
All right. Take care.
Thank you so much, and have a good day with your patients.
Okay. Bye-bye. Just starting my day.
Yeah. Thank you very much for your time. And I will, this recording will be